So, I'm very happy to talk on this topic where I look less on the biomechanical properties or the biomechanical or biochemical properties, but more on the sensory properties and how it is linked or may be linked to the autonomic nervous system and to emotional attitudes. Some of the information will be similar or the same information as I did last year for those of you who read it, but I also may make sure that I have some newer aspects where we learned in the last year. Based on two-dimensional density calculations from the Padua group, but also from the Heidelberg group around Professor Menzel, a German scientist made a three-dimensional calculation on the amount of sensory nerves in what he called fascial tissues that was basically based on the terminology anatomica, and it excluded the subcutaneous connective tissue and the intramuscular connective tissue, because based on the terminology anatomica, they are connective tissue, but they are not proper fascia. And then, but we liked his calculation because it was very exactly done on data bank. How much volume of each tissue do you have in an average adult human body? So Kalla and I, we approached him and said, are you going to do the calculation again together with us based on a more extensive functional fascia definition in which the subcutaneous connective tissue is included and also the intramuscular connective tissue. So we did that together with him and we came to the number of approximately 250 million sensory nerves in the fascial network of the human body. Now, based on that, fascia is not our largest sensory organ in terms of volume or mass, because in many people, muscles have more volume, but it is our richest sensory organ, even richer in terms of number of sensory nerve endings. Even more rich than the skin that he had proclaimed as a sensory organ before, based on the richness of 100 million sensory nerve endings and also the complexity of how it's organized. He said it's a sensory organ. So fascia is even richer, not only than the skin as a sensory organ, but also than the sense of seeing, which so far in neurophysiology has been assumed for Homo sapiens. It's our primary orientation in the world. For a dog, it's smelling, and then seeing comes secondary, how they perceive you and the world. And we have been assuming that the way how we perceive the world, unless you are blind, is primarily through the very rich stimulation and endowment in our nervous system of sensory input, and then the other modalities come in addition. But that would mean possibly our fascial perception is our richest or possibly primary orientation, and then the other senses they may come in addition. Now the question is, what are these 250 million sensory nerve endings? And the largest single group, and that was a surprise for me when it came up, and that has been shown not only by Siegfried Menzel, but also by Katharina Fede and Kalla. The largest single group are not muscle spindles, it's not the nociceptive free nerve endings, it's the sympathetic nerve endings. They make up between 30 and 40%, and no other single category could come close to them. So it means somehow it's very important to have the autonomic nervous system represented in the smallest loop and corner of the fascial network. That is much more important to have this sympathetic nervous system there than to have Ruffini endings or any other sensory nerve endings there. And then the question is, what is the function of it? And one function, of course, is assumed. You see it on this picture where it surrounds a lumen, usually a blood vessel, and that's the control of microcirculation. And microcirculation seems to have a very potent function for our health, and it's very important to get microcirculation in the tip of your little finger, of your little toe, etc. Because it's not only nutrients and oxygen, it's the whole flow of many other life functions and temperature regulation and waste products removal. So that seems to be a very important function that is regulated unconsciously by the autonomic nervous system. However, there are some, here colored in yellow, there are some sympathetic nerve endings on that very nice slide from Professor Neuruber that are terminating in the connective tissue, not in the vicinity of a blood vessel, so they seem to have a different function. And that is now the big speculation. What is the function of the sympathetic nervous system when it's not related to microcirculation? And the speculation among the neurophysiologists is that it has a trophic function with pH, so a more biochemical or nutritional function, and that these are also there for interacting with the immune system. And that's where it really gets very, very interesting for me. So one connection has already been shown that had previously been only assumed in animals, but since 2015, now it has been proven that the intrafusal fibers of the muscle spindle, the so-called gamma tonus, so that means which desired threshold of a muscle tonus your skeletal musculature has, that also is influenced by the autonomic nervous system. So that has previously been, the muscle spindle control was a voluntary control, and the sympathetic one was not known. But now it's been proven there is a sympathetic innervation, and that's not only there to control the microcirculation of the muscle spindle, but the tonus of the muscle spindle. So it means your skeletal muscle tonus, even longer than a split second, is regulated by the autonomic nervous system there. And that's where it becomes interesting how much of, for example, postural control is done by skeletal muscles and how much may be passive tonicity in the connective tissue. And that was my very earliest semi-scientific experiments when, as a rover, I went into a surgical theory and we wanted to know how much restrictions in arm elevation, leg elevation is gone after the client is in general anesthesia. Do you get more increase of range of motion? Because then the muscle tonus is zero. So all the anesthetic drugs, they make one thing for sure, to prevent the client from actively moving. So we know this would be an ideal condition to see what kind of postural or movement rigidity restrictions are due to the active skeletal muscle tonus. Then the muscle spindles are very important. And how much is the passive, probably more connective tissue associated. In the literature, there is very little research on what mobility restrictions are removed under general anesthesia. So we know that in many people, the psoas, etc., has more mobility, but very little of that. I've been working with two surgical different techniques in people, especially children with cerebral palsy. And they have a lot of improvement just by Botox injections. And Botox has no effect on collagen production. It's very specific to change the EMG-associated muscle tonus. And many of the restrictions are very much improved. So then you don't need to do any further implications. But some of them stay. And you can still not get the heel on the ground because the plantar flexors tissues are shortened there, and the Botox injection is not giving enough range of motion. So we would think that it's a passive restriction in these. You would also have it in people who have a Scheuermann kyphosis. it doesn't flatten if they lie on their belly or if they lie on their back. And that's very different to somebody who is just slouching there. And that's something I would like to be able to differentiate. Is it just active muscle tonus and you just relax the muscles with some nice esoteric sleeping music or whatever? Or is it a more structural, more connective tissue associated tissue stiffness? And on the table under complete anesthesia you can see. And the kyphosis usually doesn't disappear. And that's very different to the spastic condition. So now in the treatment of these spastic children, they have a second surgical technique. It's called percutant fasciotomy, or the Ulciban method. And they have several surgeons in Barcelona, we have one in Germany, and I was able to observe these surgical interventions. And basically under anesthesia, they come in with a little metal stick and they don't cut the fascia profunda, but they pierce it 4 or 5 times with 1 centimeter in between, and then you can stretch the fascia profunda. And I was very much surprised how much, so he does that, and then I can lift the leg. And I was thinking I should do that with my hamstring. I go to him, and then the next morning I go to my Pilates teacher and I put up my leg and I want her to faint. Because she's working with me since years, and she says, Robert, you get more flexible, and I know she is lying. So this is just one example how we need to differentiate how much of mobility restrictions or postural restrictions are due to the passive tissues and how much are due to the active EMG tonus regulation in there. And this is a very good beginning, so that under anesthesia or due to these different surgical techniques, so we can find which one is related to that. There is apparently a link to certain emotional features. For example, they have now shown people with clear, benign joint hypermobility, they are more likely to develop a higher anxiety index. And I would be very careful to say anxiety is the cause of hypermobility. It's probably if you grow up in a very fragile body, you develop a different psychological personality as if you grow up in a very sturdy body. At least I was. So it's probably cause and effect in a complex interaction in there. And that has been speculated before in all the body therapies, is that your long-term postural features, possibly embedded into your fascia, at least some of them, that they may be influenced not only by the autonomic nervous system, but also they may be in an interaction with your emotional expressions. And when I studied psychology at Heidelberg University long ago, emotions were excluded. It was all about behavioral attitudes. But now later, one scientist at Harvard Medical School, Amy Cuddy, she did some very exciting studies, at least I thought so, how she got people in terms of mimicking, in terms of a theater actor training, to assume a more expansive posture, and she measured not only their perceptual difference and their emotional difference, how they feel about themselves and about the other, and about the world and other people, but also hormonal responses. And that was very profound. So within 3 minutes, your testosterone went up, even as a woman, and you feel more secure about yourself and you're more able to take risks on a computer game, but also your cortisol level dropped. And she showed also the opposite. If she got people just as an actor to make themselves more in a contractive posture, the testosterone dropped and the cortisol got higher. And that had a big influence. So based on what has been called power posing, lots of not only actors here, but politicians have been influenced by that. And she became a superstar. So if you go on TED Talk, where you have the world's most popular informational lecture. She is #2 worldwide. So she has 680,000 viewers. So in terms of popularity, she has reached the most that any of you could hope for as a scientist. That you do good research and you publish it, and it has an impact on society. If you look at her TED Talk, it got me into tears, because she's very charismatic and she shares her own story, and it's very, very emotionally engaging how she encourages people. You know that you to follow her example. Don't be small. Make yourself bigger, and you will be more successful. So this is so far a very good story. But if you send your daughter to study scientific psychology, they will hear the name Amy Cuddy now in the first semester for motivational purposes, but not in terms of follow her, but don't follow her. Because her research studies have been the beginning of an avalanche of what has been called the replication crisis. And you need to know it unless you know already about it. This has been shaking all the social sciences to the root. And after the replication science, you cannot do science in the same way as it has been done before. Because they replicated some of her studies, and there was no change in the hormones. Of course, in the emotional attitude, but the testosterone could not be replicated. And then you think, okay, different studies. So they did it in a very big study, very much controlled, and no change. And then she even had to apologize herself. And she said, I was not as careful. You know, my assistant felt encouraged to present me some good results. I didn't follow the exact protocol. For example, if you have some people where you're on the edge to account their example, they missed one of the sessions, and here you have it. You should not decide whether you include them in the study if you know how their testosterone was, because then you're biased. But if your assistant has to decide, do I include them or don't include them, and they know the results, they should not do so. But of course, it's human, so that you do it. Also, so they found out several things, and basically, she had to leave Harvard, or she left Harvard. She's now a millionaire, and her books are selling worldwide. But in terms of her peer group, you don't want to walk. So she is now a person and a name where anybody studying academic psychology, they point to her and say, don't follow her. Follow her if you want to be a superstar on YouTube and on TED Talk, and the millions of people are followers. But if you want the 1% or less of humanity for whom scientific rigor is more important than charisma, if you want their support, then don't follow Amy Cuddy's success story. So particularly in psychology, this is a very big teaching for us. If you do premature assumptions, basically now the social sciences have been revolutionized. Because they found out it's not just Amy Cuddy's, it's the majority of psychological study, also in other social sciences. If you replicate most of the studies, you don't get the positive results anymore. And that should, for charisma, that's good, you know. But science is supposed to be different than fashion. In fashion, if you believe something, it will become true. But in science, it should be replicable. So now they scrutinize, and we have much more rigorous things. For example, the cherry picking, I've been doing it. So you don't register your examination, and at the end, you mention those features that had a positive improvement. And why should we mention the measurement that we did, that you took, in which you didn't have an improvement? But that is the reason why registered trials, in which you register your measurements in what you do, they have less positive outcomes than unregistered trials. So we all have been doing examinations where we didn't register it. where we didn't follow the protocol, but that means for the scientific community, your studies are just indications, but they are not trustworthy. So you need to have rigorous methodology. Also where you publish it. Most of the journals have a publication bias. You know, if your study says there is no significant difference after raw field manipulation, they say it's not clinically relevant, go for another journal. You know, and so it's very important that you publish in journals that have a rigorous examination. We published many of our articles in journals where if you pay sufficient fees, the majority of the articles are accepted. 70% of them are accepted. So that means the peer review is more commercial and is not very rigorous. It's nice because we can publish in 6 months. But these studies are motivational, they are indications, but if they have a positive outcome after your raw field manipulation, it's as reliable or unreliable as Amy Cuddy's research was before the replication crisis. So after the replication crisis, we need to have really rigorous methodology, and it needs to be replicable, and you need to register what you did, and you need to report everything there is, and you need to publish in journals where it takes ages to publish, because the reviewers want to see your raw data, etc. So that has been a big shake-up of the whole embodiment approach in psychology, because Amy Cuddy became kind of a spokesman, but a symbol for popular science versus rigorous science. So now people in psychology have gathered it, and they acknowledge, yes, there is no influence of postural changes to testosterone, but in terms of perceptual changes and affective changes, there have been studies that are replicable. So a year ago, they did a systematic review on all the studies, all the high-quality studies on postural changes and the effect on behavioral and affective, and they came to the conclusion, yes, there is an influence. So if you go in a more expansive posture, you get into a more positive psychology, and the opposite. But very surprising for me, they showed this is mostly due to the effect of contractive postures, not of the positive ones. The positive ones may have zero effect, but whenever you are in a contractive posture, then your brain kicks in and changes your emotions and behavioral attitudes. So for me, this new study there is actually clinically very relevant. So it means it may be useful or a waste of time to train yourself to be in positive posture. It's the 5 minutes a day or 5 hours a day in which you're not paying attention and you are in a contractive posture. And that may be in training your brain to follow with many, many other psychological functions associated with it. So it means if you focus your client's attention, how posture is an important director of many behavioral features, make them more sensitive for contractive postures, and not how positive the positive postures are. So that's something I didn't expect, and where science is good. If it shows you something that you didn't expect there, and it makes sense because in terms of long-term learning, your brain is more ready to learn from painful mistakes, and then you remember them for the rest of your life. And unfortunately, the great party you had yesterday, you may forget it. But if there was one painful experience afterwards, it will stick for you for the rest of your life. So that's my possible interpretation from that systematic review. One of the authors of that systematic review, he contacted our group because he is studying the major depressive disorder, and he wanted to find out if there are any myofascial features associated with it. And last time I already shared some elements of the study that he did, where he compared myofascial stiffness on the upper trapezius and on the mid-erector spina in the mid-thoracic spine with our dentometer in depressive patients compared with age-matched non-depressive patients. And the measurement had shown that they have a higher stiffness there. But we don't know whether that's muscle tonus or passive tissue capacities, because we only did this one type of measurement. But we were surprised to find out it's not only an altered stiffness, but also an altered elastic recall capacity in a surprising manner. Because usually if the same tissue gets stiffer, it has more elastic recoil. If you have a rubber band and the elastic recoil is stronger if you make it tighter, and it's less strong if you make it looser. So most of the myoton studies, etc., where you look at elastic recoil or dampening or breathe relaxation and stiffness, usually they go in the direction where you have more elastic recoil, the stiffer it is. But in the depressive patient, it was the opposite. So they were stiffer, but they had more dampening quality into them. And now we are speculating what that is. Maybe it's densification, maybe it's a slight inflammatory milieu. So it's a very, very interesting feature that we want to understand. Now, the professor got very motivated through that, and now it's not yet published, but it's under review. He did a larger study with a PhD student with 128 patients, in which they receive a myofascial massage of 10 minutes. And he measured the stiffness and also the dampening quality afterwards. And not surprising, the stiffness was lower after the myofascial neck release massage, but the elastic recoil not, and that was a surprise. So maybe they were able to change the muscle tonus, but not in 10 minutes of massage, so that would be not surprising to me. But the densification in the ground substance probably was not altered. What we didn't do, and that's what we are planning now, and that's where I think you get more quicker changes and also changes that may be reflective of the emotional element more, is not the compressional vertical stiffness and the elastic recoil, but how easily you can slide the skin. And we have been discussing on that. There is a very easy tool, it's called the arteriometer, and they use that in scar tissue research. So you fixate it, you have a spot of the skin underneath, and then you move the skin as much as it's able to move into one direction, and you measure with the rings on the transparent tool, how many millimeters does it go to the right, to the left, up and down, and you have a field of mobility. And then you compare that on the non-injured side, and that is a very cheap tool, but very reliable. So they have measured that for skin mobility in a horizontal direction. This is a very reliable tool. So we found out if you want to do it on a larger area, it's a little bit examiner dependent, because if you push stronger, you get more mobility, and that should not be the case. So now we developed this force control modified adherometer, and you're welcome to use it and give us feedback. And we are collaborating with Mal with this suction tool, where you basically do what your hand is doing. How easily does the skin slide in this area and in this area? And in unilateral neck pain, often you can feel it's not the stiffness, it's the shearing ability that responds the quickest to manipulation also, and also where you feel where the tension seems to be. So that is a tool that we want to use more. Basically, you have two rubber endings similar to your fingers, and you go with 45 degrees, and you push always with 5 Newton, and then you measure the displacement in the 4 direction. So this is something that we hope to be able to use in the future in that measurement. One of the persons who had motivated me to go into fascia research was a phlebologist, and he had come up with the connection that there may be an emotional influence on fascial stiffness. His name was Jochen Staubeson, and he had found smooth muscle-like contractile cells in the fascia cruris. He believed they were smooth muscle cells, but we examined them and most of them were smooth muscle-like connective tissue cells, the myofibroblasts. But he also found a rich innervation with sympathetic nerve endings, as others have shown afterwards. But he thought usually smooth muscles are innervated by the autonomic nervous system, so they are probably is a link between them. So he thought the smooth muscles regulating connective tissue stiffness are directly innervated with synaptic transmission by the autonomic nervous system nerves. But basically we found out it's not smooth muscle cells, it's myofibroblasts. And they are not in a regular synaptic transmission with nerve endings from the autonomic nervous system. But we basically found that these myofibroblasts are present, but at very different densities, not very much density, but we can still quantify them in most of the fascia profunda samples that we examined. But we had the highest density in the human lumbar fascia, more than animal lumbar fascia and more than in fascia profunda from other regions. So our speculation was that some cases of low back pain may be associated with what you have been calling frozen lumbars. And then the frozenness or the stiffness may be not only erectospinae temporary contraction, it may be a fibrotic stiffness influenced by the amount of myofibroblasts that you have there. So we have been able to measure how many myofibroblasts you have. We know from the literature that if you have a myofibroblast-driven active contraction of fascial tissues, it can be very powerful after a few months, as you see in frozen shoulder. So the frozen shoulder can become so tight that the orthopedic surgeon trying to break it up with mechanical force under general anesthesia, as they used to do more in the past, and they don't do so often now, but they still do. She may ask for help because her 10 kilogram of arm force is not sufficient. So active fascial contractility can be very powerful if you have sufficient time. But if you have only a couple of minutes, it's ridiculous because the speed of contraction is about 1 centimeter per month. So if you have a contraction happening in response to your manipulation, I think you have to find another explanation, but not myofibroblast-driven active cellular contractility that you have there. We hadn't found a direct hormonal influence on myofibroblast contractility, but we got a strong response to TGF-beta, which is not an hormone, but it's a cytokine. And we were not aware that there is a link from chronic stress regulation to CGF-beta production in the human body. And that was a surprise for us. But that has been clearly shown in the literature that chronic sympathetic stress activation can influence the amount of TGF-beta that you have in the tissue. Most of the TGF-beta is produced by the fibroblast, and they store it in the ground substance. And it was even shown that the influence of the sympathetic nervous system on your immune system, that you have a different T-cell activation when you're under chronic stress than when you're not under it. It needs the fibroblast as a mediator. So your autonomic nervous system cannot influence your lymph nodes to change the immunal condition unless fascia contributes. So it's not just a voluntary, So the two of them cannot communicate with each other unless you, as a fascial fibroblast, say, I support your communication. So it means the influence of the autonomic nervous system on the immune system in many conditions needs the active fascial contribution in addition. But we didn't know any hormonal influence because in our several contraction studies where we had suspended a little piece of a fascial tissue in a physiological solution, we could only make experiments for a couple of hours and then the tissue becomes unresponsive. But colleagues have been doing it in a petri dish, which is very different, but you can keep the cells in a very non-representative condition. So they are swimming in doping solution, and then you can keep them alive for several days. And they found out if you stimulate their adrenaline receptors, you have no response in the first 6 hours. That's when we measured. So they confirmed we haven't any response of adrenaline. Also no response after 12 hours, but a profound response after 24 hours, where they then produce more TGF-beta. So now, coming through the back door, we got the original hypothesis from Schleip seems to be correct, that an adrenergic stress-associated state could have a profound impact on your stiffness regulation, but not in the first hour, not in 5 minutes. But after 24 hours, yes. Then, so acute stress, probably not, but chronic stress may have a hormonal influence on your stiffness regulation in the connective tissue. One aspect in the whole psychological field that has been developing and becoming almost like a big fashion now is the interoception. How you feel your body not in relationship to load, to movement, but in terms of temperature regulation, hunger, and other physiological conditions. And we know that this is usually done by free nerve endings, which are non-myelinated, and that they are projected to a very different part of the brain than your postural regulation is done. They are projected to the insula. And the insula is much more influenced than your somatomotor cortex is also influenced, but to a much lower degree by emotionally associated brain centers. So your proprioception, you can try to be neutral if your toe is to the right or to the left. But if it's about interoception, it's impossible not to have charismatic emotional brain centers predicting what you should be feeling at the last minute. So if you get some food, before you even taste it, you have a strong expectation of how good the wine or the food will taste, based not on what's coming up from your belly, because you haven't eaten it, but because of other brain centers. So interoception is much more stimulated by predictive coding than and by your expectation factors and the emotional quality that you have there. Very, very profound for us, a much higher number of nerve endings in your fascial tissues are devoted, if they are sensory receptors, to interoception than to proprioception. So that is definitely a potent function where also fascial manipulation may have a profound effect, not only on your posture, but on your interoception, which has very much how old you feel, how vital you feel, how cold you feel, is very much related. And also how much belonging, if this leg belongs to you or if you feel like this doesn't belong to you, which is in mastectomy often a very important thing, that when they walk, their arm doesn't swing because they feel this is not my arm. And that has nothing to do with proprioception apparently, but with interoception. And so this is a very important dimension, how we can foster that. There is one dimension in interoception that has been getting more attention because it led to a discovery of new touch receptors in the skin and the subcutaneous connectives under the skin, the tactile C fibers. And they are related to grooming, and they have a profound healing potential. And there it's very important that the client feels safe and that you do it at the right speed. And they found out recently it's between 1 centimeter per second and 10 centimeters per second, and you need to smile at the client before and make social exchange. And then a few minutes of that grooming contact can make them sleep better, their immune system is much better. And, but it depends also how cold and warm your hand is. So there is lots of research on these tactile C fibers and how profound they are. But now recently they found out there must be a different type related to the same social regulation, stress regulation function, because when they use pneumatic pressure receptors, they build up a strong pressure over 6 seconds, held it, and then basically it's a lymph drainage device. I have it at home. And if you do that at the right speed and at the right pressure, the same area of the insula are activated as you have in a grooming touch. And they haven't found the nerve endings for it yet, but they know it must be myelinated nerve endings related to interoception. So they found that out by doing some experiments with Ian Waterman that I know, who has no myelinated sensory nerves below his neck, and they used him and other people, so they know it must be myelinated nerve endings, probably not in the skin, probably in the intramuscular connective tissue. And I speculate it's Golgi or Ruffini endings, who may have an interoceptive function that has a very strong healing potential there. And the Pacini is not so likely in the muscle spindles, because they respond to slow pressure that you have there. So that's why I was excited also on Professor Caro, thinking that when you have the myotendinous, the myomuscular, the myofascial junctions, you may have some small Golgi receptors, not Golgi tendon receptors, but Golgi connective tissue receptors that may have a secondary interoceptive function. That's pure speculation. But it means there is a lot for us to study in the future. Let me summarize what I already last time looked at, the relationship of that with the immune system and mechanical stimulation. There is an uncontrolled field study going on in Hollywood where a woman is marketing a vigorous fascia manipulation called the fascia blaster. And thousands of women think she's a hero because they got a more beautiful body in terms of cellulite by a vigorous fascia stimulation. But also close to 100 women got together with a lawsuit, and they said it damaged their health. And if you go into the law data, which you can go, it's very interesting for me. So from those claims, I'm not judging whether they are right, but I would have expected bruises or broken ribs. But the majority of those claims were unexpected to be. And that's where science gets interesting. It was a flare-up of Lyme disease, a flare-up of shingles, of Epstein-Barr virus. So where their immune system apparently got weaker in the constant interplay with some bacteria and viruses that have been in your body 20 years ago, but you conquered them. But when you conquer them, they are still living in little nests, not in your gut, but in what you could call the fascial microbiome, or the interstitial microbiome. So we have millions of little bacteria, viruses, and other so-called primitive organisms living in our fascial net outside of our gut, and many of them are hiding in the epidural. And they are waiting for a lucky day in which your immune system is sleeping or busy with itself, and they have prepared for it since 20 years. And when your immune system is weakened, maybe by the rigorous rubbing where you did too much and you have small inflammation all over your body, then they have their lucky day. And then they break up, and it can really lead to serious reinfections in your body. So in a more controlled study, they looked at marathon runners, and they have also shown. So if you do excessive mechanical sports stimulation, your immune system is weakened unless you are used to that. So it has been shown that mechanical stimulation and the amount of it that you have can influence the immune system in a negative way by too much mechanical stimulation. But a couple of months ago, they did one with the astronauts that have been spending several months in weightlessness, where you have a lack of sports of mechanical stimulation, and they showed the same. So they had a flare up of Lyme disease and of shingles and something, and they also were able to measure it in the gene activation of their leukocytes. So the lack of mechanical stimulation, or maybe, no, it could be also the fluid pressure that you have. But at least the microgravity condition that you had, which I say is mechanical stimulation, directly or indirectly, had a weakening effect on their immunal status that you have there. So it means that our immune system is in constant interaction, not only with your enteric microbiome, but also with your facial microbiome. And I was shocked when I did the literature of how many microorganisms we very frequently have in our body. So the Epstein-Barr virus, 90% of us have that there, and you will see some familiar organisms and diseases. This is very interesting. Toxoplasma, usually cat owners have it. And in animals, it has been proven that it has a strong impact, or can have a strong impact on emotional attitudes. So a mouse that has the toxoplasma, which is smaller than a virus, so you would think it's very primitive, but the toxoplasma microorganism is so smart, so if it's in the nervous system of a mouse, the mouse becomes fearless in contact with cats, which is not good for the survival of the mouse, but it's ideal for the distribution of the of the toxoplasma. So that is how smart they are. They also showed that wolves who have toxoplasma have a 43 times higher likelihood to become the alpha male, which is probably good for them, but not so good for their competitors. And there are strong indications, but as we speak, they not yet proven that may be also explaining the emotional behavior of your boss or of your competitors. That if they become like a future alpha male, it may be not their fault. It may be the toxoplasma. So who is you? So we know that the immune system is in constant interaction with the emotions and with the autonomic nervous system, and that fascia is involved. That new insight has led to a re-exploration of some of the unsolved questions in myofascial therapies, and they reopened fibromyalgia, because so far no explanation was really convincing. Serotonin is a little lower, the endomysium is 10% thicker, but that doesn't explain how profound fibromyalgia is and how different it is to other myofascial pain or to depressive disorder, anxiety, etc. So now they looked for the autonomic nervous system, and they found a profound, not a 10% difference, a profound difference in the innervation in the subcutaneous connective tissue for the microcirculation, apparently where the shunts are. So they have a dramatically diminished number of sensory nerve endings for temperature regulation in the subcutaneous connective tissue. And then you suddenly listen, because they are always complaining that they have temperature regulation problem. If they have cold feet, it takes them longer to come back to comfort. If the door is not open, like last night, if you have fibromyalgia, you have to go to the toilet for 20 minutes before you can come in. So that has been known, but it was not accepted as a major driver. So maybe the regulation in the microcirculation may be the primary dysfunction, and then the motor and the sensitivity that they have in terms of mechanical pressure may possibly be second. But we know now the autonomic nervous system is significantly involved, and when you know that the autonomic nervous system is involved in a pathology involving myofascial tissues, you don't stop now after all these insights, and you also look, if the autonomic nervous system is involved, you have a strong guess that the immune system is most likely also involved because they interact with each other. So in this recent study that I want to finish with, they injected blood serum from fibromyalgia human patients into mice, and they developed fibromyalgia symptoms. But only if the blood serum came from fibromyalgia patients, not from other pain patients or from healthy pain patients. And then, of course, they wanted to know what is it in the blood serum, and they speculated it could be the antigens of the immune system, and they cut it out, all the antigens, and the effect was not there. So it means the antigens are able to elicit fibromyalgia-like symptoms in mice. It doesn't mean they are the cause in your patients, but it definitely shows there is a strong immune system component involved. So then what can we do if we know that fascial stiffness, fascial sensitivity is in constant interaction with the autonomic nervous system and with the immune system? And one solution could be to look at fluid stagnation. And that is one new model from Jay Shah's group, where they say whenever you have myofascial pain, you have a stagnation of lymph, of microcirculation, and also the liquid in the ground substance. And that seems to be the factor in the astronauts, that seems to be the factor in the fascia blasters, but also in the marathon runners, that your fluids are stuck. And then the healthy interaction of your immune system, driven by the autonomic nervous system, and your microorganisms, but also the cytokines and the free radicals in your body, they seem to be negatively affected. So this is the last article that I want to focus on by Patricia Houston. She also, similar to Jay Shah, she thinks it's a stagnation of the fluids in the more liquid areas of your fascial body. That seems to be a main driver for many pathologies, and she looks at different lifestyle features. So how can we practice a lifestyle from eating, from meditation, from sleeping, from regular exercise, but maybe also foam rolling and getting the fluid stagnation out of pockets that you don't reach with your daily jogging, may be a beneficial approach to allow a better interaction between the immune system that needs a microcirculation, that needs a lymphatic flow, but if there is no flow, the immune system is not capable to fight with all the microorganisms in there. So thank you very much.